Welcome, everybody, to the March Research Matters. We're so excited that we can host this and that we're not having another snowstorm to cancel Research Matters. Just like we did in January, we're going to start off with a presentation from Eriko Iwatate about clinicaltrials.gov. So Eriko, turn it over to you.
Thanks, Josh. Good afternoon, everyone. I'm Eriko. I work in Regulatory Support Office with Resija Nambia. So in January Research Matter, I reviewed why we need to register and results reported in ct.gov. And there are many agencies and organizations requiring ct.gov reporting, and there are penalties associated for non-compliance. So today, I want to review which study needs to be registered. So first thing first, regulation and policy require clinical trial to be registered on ct.gov. So you can put observational studies such as biomarker validation studies or epidemiological study if you want to, but it is not required for the most of the part. So I'm listing three very similar clinical trial definitions set by NIH, FDA, and publication policy. So say if your trial is NIH-funded trial, then you need to go by their clinical trial definition and follow their policy. And then say your trial is not NIH-funded and does not involve any FDA-regulated products, but PI plans to publish the study results in journal, then you need to go by this ICMJE definition. And then if it fits the definition, you need to register. So today I want to first give example of non-clinical trial. A study appears to be clinical trial, but it does not require ct.gov registration. So one of the common example is a biomarker validation study. So for example, so if your investigator is prospectively enrolling two cohorts, so one is elderly patient with cognitive impairment, and then the second cohort is the elderly without cognitive impairment to assess the metabolic activity using PET scan. So your hypothesis here is metabolic activity that is measured by PET scan is different between these two cohorts. So metabolic activity is a biomarker of cognitive impairment. So in this example, PET scan is probably considered more than minimum risk research specific procedure, but it is not intervention, right? Because having PET scan or not does not change the health outcome or change the course of patient care. So PET scan in this example is just the observational tool, not the intervention, because you're not assessing the effect of PET scan in this study. So therefore, it does not meet any of the previous definition of clinical trial that is set by NIH, FDA, and ICMJE. So it does not require ct.gov registration. So now I want to give an example of clinical trial. So this is the NIH clinical trial definition. So in general, if you answer yes to all of these four questions, then it is a clinical trial, and therefore registration may be required. So traditionally, when you think about clinical trial, we think about randomized control device or drug trial. But NIH definition of clinical trial, as you can see in this image, their definition is much broader than that. So clinical trial include pilot study and behavioral intervention. So for example, if an investigator wants to assess the effect of educational program on the hospital readmission. So here education program is intervention, and then hospital readmission is a behavioral outcome. So that is clinical trial per NIH definition. And their definition also include mechanistic trial. So those are considered early translational studies. So say you give metformin to everyone and then assess insulin sensitivity. And so that is considered clinical trial per NIH definition. And then also by this definition, most of the chart review are actually not considered a clinical trial, therefore does not need to be registered. However, there's an important exception. So pediatric post-market surveillance of device product, so which typically done in retrospective, like observational study fashion, are considered registration required study under FDA. So once you determine that study is a clinical trial, then in general, a clinical trial needs to be registered if the PI is IND IDE holder, or if it meets the definition of FDA applicable clinical trial, and if your trial is funded by NIH in whole or in part, otherwise if required by funding agency. So PI really needs to read the term and condition of their contract with funding agency. And then also if a trial involves procedure claimed to Medicare and Medicaid, or if required by journal for publication, as I mentioned. And for the results, posting are required if it meets the following on the right. So again, important thing to remember here is that one trial, one ct.gov record. So multi-site trial are not registered by individual site. So if your trial is a multi-site study, it must be registered only once. So in general, IND IDE holder or main site PI and industry sponsor will be responsible party to register the trial on ct.gov. So your PI must coordinate with all collaborators, sponsor before registering trial on the ct.gov to avoid the duplicate. And then say PI is unsure about whether study meets the definition of trial, because some trial are very tough one, like gray. We generally recommend to register anyway, as there is no significant downside of registration. So this flow chart summarizes what I just said. So right side on the document is helpful tips to answer each question in the blue box on the left. So this flow chart is available in our website, and also I can also email you if you wish. So our recommendation is before you initiate ERB submission, please go through this flowchart with your PI and then assess whether the trial requires ct.gov registration and results reporting. So now let's talk about metrics. So according to FEDA non-compliance trial tracker website, our compliance rate proportion was 68.2% in last May. And so this public website takes data from public ct.gov interface. So this is what the public sees in terms of UT Southwestern compliance for FDA regulated trial. So in February, like January, so we are able to maintain 100% compliant. So thank you everyone for your effort. But again, important to note that this 100% compliance is for FDA regulated applicable clinical trial results only. So it does not include NIH funded trials that are not applicable clinical trial or trial that are voluntary registered. So as I mentioned last January, so we generated own metric that include all trial and their compliance directly from ct.gov internal database that are only accessible to institutions administrators. So this shows overall real-time compliance for all UT Southwestern records. So blue histogram is the total number of trial that is registered under UT Southwestern account. So green one is the number of record with no problem. So whatever the difference between blue and green are bad one. So those orange and red bars are need some attention, has some problem. So the orange one is a problem record that are not FDA trial, but has been flagged in the system with some sort of error, which must be corrected. And then the red one is the FDA regulated trial that are subject to federal monetary fines. And actually these two results are currently under ct.gov review. So our goal is to continue with 100% compliant in non-compliant tracker website, this website. And we want this orange and red one to be as low as we can. So if you have any question or if you need any assistance about clinicaltrial.gov, please email us. So here are the list of contact person for ct.gov related issues. And I'm including list of selected resource. So thank you.
Thank you, Eriko. And we invite everybody to provide comments in the comment area while we're switching presentations. Just give it a couple of seconds just to make sure there are no questions coming in. Okay, well, with that, we'll go ahead and get started on the rest of the presentation for today. We have Yvette King from the IRB team here to present on repositories and registries. Before we get to that, we just have a couple of announcements and housekeeping items. So some quick announcements, just like always. If you have any questions in this Microsoft Teams live event, please type your question into the Q&A. The slides will be sent after this session, and the video is immediately available if you click on the same link that you clicked on to get into this meeting. We are now posting the videos on our website as soon as we can. We did have a delay because we needed to get closed captioning completed on the videos to have them compliant once they were posted to our website, but we've been able to work through that backlog, and now they should be posted to the website sooner than they had been before, and we apologize for any delay in that. Any attendance certificates will be sent to those who've logged in with a valid email address, which means that you're signed in and joined through Teams. So if you're not able to do that, just send an email to hrpp@utsouthwestern.edu, and we will send an attendance certificate for you. So some quick updates. So we just want to congratulate our fearless leader, Rhonda Oyelopo, because in February she was promoted to Assistant Vice President of Human Research Administration. We're very excited and so happy for her that that change has been made. Also excited, Hind Nadeem has been promoted to Senior Regulatory Analyst, and now in her new role, she'll be supporting the Reliance and SIRB teams. And concurrently with that change, Erica Howard-Dunn is actually transitioning back to supporting the analyst team. We'd like to welcome Jasmine Armstrong. She's been with us since January, but because we didn't have a February Research Matters, we didn't get to announce her arrival. And we also want to say farewell to Alwell Mahan and Allison Griffin, who also left in February, and their departures would have been announced, but we didn't have a February Research Matters. So with those changes, we did have 2 regulatory analyst positions posted. And I'm realizing now that I did not also include another promotion. Kim Mapes was promoted to the program manager of the quality and monitoring team. I'm so sorry, Kim, that I didn't put that content on here. I knew I was forgetting something. But there is a regulatory monitoring analyst position posted as well. So if you have any questions about the open positions or potentially who you need to be contacting with questions in the office, please feel free to either contact any of the HRPP staff with questions about who to contact, or Rhonda and myself about the open positions. I just wanted to put this email or this slide back in. This is the same slide that was shown in the January Research Matters, but Just a reminder that we did send an email out in January as a courtesy reminder that study teams need to monitor and ensure that city education remains up to date for all engaged study team members. We updated our policy in January of 2017 or sometime in 2017 with an effective date of January 2018, adding a 3-year expiration for your city education. Because of that 3-year cycle, that means that many people have training expiring in either January through March of 2021, and quite a few people March through December of 2021. And that is causing a disruption. It caused a disruption. We started to see that in January, and we're continuing to see that. It's slowing reviews down. So just remember that that email did identify ways to prevent the training from expiring. And it also means that the staff may be removing people if we're not getting responses back that training will be completed, just to help facilitate a quick review of new studies and continuing reviews. Some quick EIRB updates. So these changes will be put into the system tomorrow night, which is March 17th. So starting the morning of Thursday, March 18th, you'll see these changes in the system. One of those changes is that with a recent framework upgrade that we had in 2020, the name, the two left-hand side things, the name of the person logged in, and then the study that you were looking at changed color. And we've now added, had AIS change that color back to white, so that way it's easier to see against that blue background. This may have been browser specific in some instances, but from here on out, starting on Thursday, every browser and every screen, you'll start to see that text change back to white font so that you can read it easier. We updated questions 6.15 and 6.17, essentially just to try and consolidate where patient-facing documents or documents collecting information would really exist. So you can see there's the old text where 6.15 was just questionnaires, and 6.17 was really meant to be all other study documents. And now we've transitioned the patient diaries and case report forms into question 6.15, so that way 6.17 really does just remain all other study documents. If you have an existing study where don't expect that you're going to move documents around, this really will just to help start clean up new studies going forward. We also have a major update to the Reliance workflow. So the old way that the Reliance studies move throughout this parent smart form, this would be new study submissions, is that they would skip after they've completed section 5 to section 7. So we skip over section 6 completely. And most of the information that a non-Reliance study would complete in section 6 would be completed in section 12, including questions about drugs, devices, and radiation. However, now there's going to be a new flow, and this will include all EIRB Lite studies. It will not affect the legacy studies. Reliance studies will move from section 5 to section 6, complete specific questions in section 6, and then move on to section 7, 9, 12, and throughout the rest of the smart form. What that does is it means that Reliance studies will now answer questions 6.3, 6.7, 6.15, and 6.17 as applicable. So this allows us to capture is the study intervention or use of data. In 6.3, we'll see a quick snapshot of that in a second. What type of study activities will be conducted, which allows Reliance studies to initiate IBC review. That was a big hole in the EIRB Lite smart form that we really did not see until it started to affect live studies. One of the reasons that we're doing this is it hopefully simplifies the design of the smart form for everybody. Having different versions, I think, can sometimes be confusing, but it also helps simplify the reporting for us out of the smart form. Instead of multiple questions asking about drug or device usage, now we're going to have one question that will really be the source of truth for all studies. And Reliance studies will also route to Section 24, which was previously hidden, so that we can capture if data or samples are going to be transferred out of the institution and compare those against the DUAs, DTAs, and MTAs that we are involved in on an ancillary review process with in e-agreements. So as we transition this, 6.7 will be auto-completed for Reliance studies, which completed the drug, device, or radiation questions. So if your study answered yes to the radiation, drug, or device questions in Section 12, those options will automatically be checked in 6.7. 6.3 will need to be answered for all Reliance studies the next time the modification is submitted. So as you're going through and you're completing a modification, EIRB will note that 6.3 is a required question and that it's not answered. But it's super easy to navigate to question 6.3 and just answer that very quickly. And so this is sort of what it will look like inside the Reliance Smart Form. You'll notice 6.4 through 6.6 are all hidden, and then you will notice that 6.6 through 6.14 remain hidden. So this is an example of a Reliance study where 6.3 was not completed, and the study team will need to complete that the next time a modification is submitted. Similarly, you'll see this is actually a live example of a real Reliance study that did include drugs, devices, or biologics and radiation, and those were automatically checked by the system and will not need to be rechecked by the study teams. The one thing I will note is that if you do have banking, returning clinically relevant results, deception, infectious agents, or non-aiming beam lasers, there was no way for us to make sure those were automatically checked. So you can clean up your study by checking those things. Just that way it's an accurate representation of what your study is truly doing. So with that, those are all the EIRB updates. If you have any questions related to those updates for Reliance studies, please feel free to reach out, but hopefully this will have a very minimal impact on you and make it even easier, we hope, moving forward. So with that, we now move on to the main content for this presentation, which is the repositories and registries, and I am delighted to turn it over to Yvette King.
Thank you, Josh. I appreciate that. Okay, we'll be presenting repositories and registries. So our objectives today are to define and explain the difference between repository and registries, define the responsibilities of the investigator, who is also known as the administrator, address the risk associated with a repository and registry, and the responsibilities of the IRB as well. So a data repository versus a registry. A repository is known as a collection of biological specimens whose organizers receive, maintain, control, access, permit use of, and often code information and specimens to the donor's identity. So it's usually including demographic and/or medical information. A registry is a collection of information, elements, or databases whose organizers receive, maintain, control, access, or permit use of, and often code information and specimens to the donor's identity. Now, those both sound very similar, but if you notice, the repository usually includes demographic and/or medical information. Both of these need to be submitted to the IRB for review when used for research purposes, and both require oversight by the investigator or manager in the IRB. So research databases include de-identified research databases may be obtained after the completion of a study. And this is a new common rule, requires that this be disclosed in the consent form. Additional questions may arise in the future that can use the same data set. So if there's an intent to set up a registry, then the informed consent document should include language for subjects to either opt in or opt out of storage of their data for future research purposes. You can't just automatically do that for them. This registry must be separately IRB approved. So not as a sub-study to the protocol approved to enroll participants. So that means you have to submit this separately. You can't tack that on to anything extra, can't hide it anywhere. This has to be a separate submission. The components of a repository are as follows. Collectors of tissue samples, which the IRB reviews, informed consent, submittal agreement. Storage and Data Management Center, IRB review, informed consent. The recipient investigators are the recipient agreement and local policies. So all of that has to be put together for a repository. And human repositories may be combined with data management centers. So, you know, all of this could be combined together for a human repository. The examples of a registry and repository. So registries can be public or private, and those fall under things like Centers for Disease Control and Prevention, state cancer registries, the U.S. Census Data Bank, the National Library of Medicine Hazardous Substance Data Bank, that's a long one, the National Practitioner Data Bank, and repositories are things such as the National Human Radiobiology Tissue Repository, the National Institute of General Medical Sciences, Human Genetic Cell Repository, the NIH Genotypes and Phenotypes, and NIH-, which is the National Institute of Child Health and Human Development Data and Specimen Hub. So that covers a lot of initials in there. But those are examples of some registries and repositories. You can actually visit any of those sites to kind of get an idea of, you know, examples of what all is included in there. Examples of non-research repositories can be created and maintained for purposes unrelated to research. So that's health records intended for diagnosis, treatment, billing, marketing, and quality assurance and quality improvement. So those, the QA/QI obviously are our Y2, Y1 forms that you guys might submit. So when is IRB approval needed? IRB approval and consent is needed if there's a planned collection of additional tissue beyond what is needed for the clinical procedure, or when there's discarded tissue is obtained with identifiable information for analysis. So a note to this is secondary analysis of de-identified specimens do not require IRB review and approval. However, federally funded studies may need some documentation of an IRB determination. So always keep that in mind. If it's something that's federally funded, then it might require documentation that an IRB has at least made a determination on your submission. The investigator's responsibility, they must submit to an IRB, maintain the data collection, provide consent, make sure that they cover the security and the confidentiality of their subjects, obtain the maintenance, access, and storage. They need to make sure they cover all of that, and the distribution and tracking for their studies. So it's the same as any other study, basically. They need to make sure they cover all of the details and that they are governing and guiding their study and conducting it accordingly. The risk in this involve obviously security, inappropriate access to the information. Like with any other study, you have to make sure the only people who have access are who is listed on the study team. The confidentiality, the same as the subject no longer wants to be a part of the registry. You need to make sure that's covered, but you still maintain their confidentiality according to regulations and processes. And make sure there's no misuse of the data. And that depends on the terms of the agreement. So you must follow whatever the agreement is. So this is just kind of a little cartoon, but it's to show you that you need to state exactly what you're going to do with this tissue. As the previous slide showed the risk, you cannot misuse anything. You can't decide in the middle of your study that you are going to do something completely opposite with it. You have to follow exactly what you said you were going to do. The best practices are to describe how you will secure the data and the confidentiality. Appropriate data use agreement might be required when sharing any data or specimens between different institutions, such as universities, government agencies, other nonprofits, and for-profit companies. You also must describe how you will maintain the registry and the repository, describe the consenting process, describe and develop a training plan for your study personnel, describe the intent and process in full detail throughout your protocol. None of this is different from any other regular submission. So basically, you got to do the same thing. There's no shortcuts on it. The IRB's responsibilities include, we must adhere to the regulatory guidance found at OHRP. These are the different links, the FDA and HIPAA, of course, and then as well our HRPP policies and procedures, which are listed online on the website. And so UT Southwestern IRBs do not allow repositories housed at UT Southwestern to piggyback or be included within another study. So I want to reiterate that. We do not allow repositories housed here at UT Southwestern to piggyback or be included within another study. Repositories are not meant or intended to close. And I appreciate you and for listening to me. And if you have any questions, I've already told Josh he can answer them.
Thank you so much, Yvette. That was really fantastic. I've seen that we've gotten a couple of questions coming in about the city training, so we'll give some time for questions to come in about registries or repositories. I'm not seeing anything pop up. As a reminder, next month, I believe we will start officially on the review of different types of submissions, exempt, expedited, full board. There probably will be a slight modification to the overall schedule to talk about Reliance and SIRB, potentially sometime in May or June. So look for that update on our website somewhat soon. And if you do have any comments or potential topics, feedback, that will be included in your attendance link, the opportunity to provide feedback on this session. I'm not seeing any questions come through, so thank you so much to Erico and Yvette for presenting today. And if you have any questions, I'm just going to shoot those emails right back to Yvette. So thank you everybody for attending and have a great rest of your day.